So I'll keep things on time. I wanted to see if I was attending such a talk, what would I like to be answered? And what are the clinically relevant questions in HCV-HIV co-infected patients? What is the goal of treatment? When and who should be treated? How should they be managed before, during, and after treatment? And so, like with any other condition, we start with what is the burden of disease. And this has been a challenge to accurately determine what is the prevalence of, or the true prevalence of HCV viremia. And this is one of a very comprehensive study, which actually was published in 2017, but gives you prevalence and genotype distribution of hepatitis C throughout the world in 2015. And there are two ways of looking at it. One is to look at the prevalence, and as you can see, focusing on India, that it falls in the low prevalence region. But when you look at the actual number of people infected, of course, that translates into a substantial number, 4.5 million people estimated in India. And out of all of those countries, just 30 countries account for 80% of the HCV infections. And among those 30 countries, it's just these top 5 or 6 countries listed here: China, Pakistan, India, Egypt, Russia, and the United States, that account for over 50% or 51% of the HCV infections. Coming to HCV prevalence in India, and Dr. Sunil Solomon and his group have done a lot of work and are continuing to work to not only establish the HCV prevalence within India, but also to coordinate testing and care for these patients. This one shows the HIV and HCV prevalence, again, from Dr. Solomon's group. Focusing on going back to the earlier study and just focusing on India, one other thing that the study has done is to come up with estimates for the genotypes. And as you probably know, that the most common genotype in India is genotype 3 with 64% cases, and the second highest is genotype 1 if you add up all the 1A, B, C, and other. And that has implications for treatment. So the key findings from this study, also known as the Polaris study, are that in 2015, the global HCV prevalence was 1%, or 71 million cases. Surprisingly, they had much lower infection rates for India and China. And there may be several explanations for that, and one of them may be that the rates for HCV are usually measured in high-risk groups, and then the population is used to extrapolate those numbers, and that results in an overestimation. Another reason could be HCV rates are mostly based on antibody prevalence, and as you know, about 20% of patients can clear the infection spontaneously and would not have an active infection. And as I mentioned, that these 6 countries account for about half of the global HCV infections. In addition, another thing to point out is that the number of cases or number of patients who were on treatment is quite low. So in 2015, only 1 million patients had received treatment for HCV. And out of those, 2/3 were with these newer direct-acting antivirals. And 700,000 had achieved sustained virologic response. So going back to the questions again, so what is the goal of treatment? And this is from the AASLD HCV Treatment Guidelines. And so the goal of treatment is to reduce all-cause mortality due to Hep C. And this is by achieving virologic cure, as evidenced by sustained virologic response. And again, this kind of shows the same thing. So this y-axis shows you the HCV RNA levels before treatment, and while on HCV treatment, the levels fall rather quickly. And at the end of treatment, 12 weeks after finishing treatment, when you measure HCV levels, it's not detected. And so this is really the goal of treatment, to completely clear the virus from the body. And what are the recommendations for when and in whom to initiate treatment? And this has become very simplified now. Treatment is recommended for all patients with chronic HCV infection. And the only exception to this is those with short life expectancies that cannot be remediated by treating HCV or by other measures. So essentially, anybody with chronic HCV infection should be treated. And so these are guidelines that are freely available online. These are from the AASLD IDSA guidelines. And then you also have the Indian National Association for Study of the Liver guidelines. And these are probably ready for an update. These are from 2016, and the association's meeting in August, and I think they will come up with some updated guidelines. So I just focused on the INASL guidelines, and these were the things that they had mentioned as part of the pre-treatment assessment: history and physical exam, baseline labs, liver and kidney tests, checking for hepatitis B and HIV, measuring HCV RNA levels, determining the genotype, checking for liver fibrosis, also doing psychiatric evaluations. I'm not sure what the relevance of that is to the current regimens, but that's included because some of the patients still may be receiving interferon. So there are some situations where interferon is still indicated. Pregnancy test, this is because of ribavirin or the possibility of using ribavirin in the regimen. This is the CDC's HCV testing algorithm. So just to go through that, if you suspect hepatitis C in a patient, the first thing to do is to start with HCV antibody test. And there are some shortcomings of that. There can be false positives and false negatives, in the sense false positives in those who have cleared the infection, false negatives in patients who are immunosuppressed or who have an acute infection and have not yet developed antibodies. And if it is reactive, then confirming with HCV RNA. HCV RNA is not detected, then there's no current infection. But again, this may have to be repeated if it's tested too soon after an infection. And if HCV RNA is detected, then they have current infection and then linkage to care. And there is some modification to this, as I'll show you as we go along. So we were interested in looking at clinical variables to identify seronegative HCV co-infection in HIV-infected individuals. So the ones that I alluded to, those who are immunosuppressed and may have a false negative HCV antibody test. And we had done this study in San Diego. So we identified readily available some of the lab values or historical data information, such as history of IV drug use, ALT greater than 50, platelet counts less than 200, and detectable plasma HIV viral RNA, and black ethnicity as factors that were associated with seronegative HCV infection. In addition, we also looked at, so this was a multi-center study, and the seroprevalence of, or the IV drug use varied widely within the different sites. And so we looked at it by the IV drug use, and that also played an important role. So moving on to HCV diagnosis, the next thing to consider is, after the antibody, is the PCR test. And it can be a qualitative test, which just gives you a positive negative value, or a quantitative assay. There used to be a lot more emphasis placed on doing a quantitative PCR during interferon era, and that was because the response to treatment, early virologic response, or had an implication to how likely a patient was to clear the virus, and it's not that important in the current era. The other alternative to PCR is HCV core antigen. PCR obviously has limitations due to the equipment needed and also the cost of the assay. And so there is an interest in looking at HCV core antigen as an alternative. And another thing to keep in mind is to determine the extent of liver disease. And this, again, is important for determining what treatment regimen to use and the duration of treatment. Clinical assessment is only useful in decompensated cirrhosis, so it doesn't really have a lot of value. The gold standard used to be biopsy, and as we know, liver biopsy has associated morbidity. It's expensive, and sampling errors can occur based on what part of the liver has been biopsied. So there were other things that have been used but are not as good are biochemical tests such as the APRI and FIB4. Currently, imaging or FibroScan is the new gold standard. There are other modalities such as ultrasound and MRI can also be used. And FibroScan, this shows you the FibroScan machine and the patient undergoing the procedure. And so while I was visiting YRG more recently, I saw the exact same machine there. And so we have a FibroScan machine here to look at fibrosis. It's coming to HCV treatment options. Again, I'm not going to go through all of those treatment options, but these guidelines list all of the conditions and drug interactions, and so you can look at the AASLD, IDSA guidelines, and then more relevant to the Indian setting, the INASL guideline. But to give you an idea of the sort of explosion in the number of treatment options that are available for Hep C, this lists the different drugs that are available. And I actually had to add these below to show you the newer drugs that are currently available. The INASL guideline talks about, so this is for all the different genotypes, but just focusing on the genotype 3, which is the one that is most commonly seen here. So the recommended regimen is sofosbuvir, daclapivir for 12 weeks, or you can add, they recommend ribavirin, and then for patients with cirrhosis or with an alternative regimen. So this is where the pegylated interferon still comes in the Indian guidelines. Only looking at this combination that's currently available in India, and this is from the LE2 study, where so just the SVR12 was 100% in 1B and non-genotype 1 within 12 weeks, so very effective. And this is for genotype 3 from the AASLD guideline, and you have the sofosbuvir, valpatasvir, which is also available in India now. So those, both of these options are available here. So how do you select? Currently, there are just these two options, so there isn't a lot to select from. But the most important factor that plays a role in selecting what regimen to use is the drug-drug interaction, really. So again, just to show you that the drug-drug interactions are really an important thing to consider while determining what regimen to use. And again, I'm not going to go into the details, but just to highlight the fact that that is the most important issue. So going back to that flowchart that looks at HCV management, one of the things that has been taken off or can be taken away is the genotype because of the availability of these pan-genotypic regimens that really simplifies the treatment. So what are the current challenges to Hep C treatment? One of the questions that may was considered and I think has a definitive answer now is, what is the impact of HIV co-infection on response to these directly acting antivirals? And the brief answer to that is there is no difference in the response to directly acting antivirals. And this has been shown in multiple studies. The most recent one is the abstract from CROI that was presented looking at the DAA treatment response among HIV, HCV co-infected patients, and the treatment response was, or SVR12 was 98.2%. I think that question has been laid to rest, that patients who are co-infected respond equally well to these newer drugs. The next issue is now, since we are able to treat patients or cure patients from Hep C, there is the issue of Hep C Re-infections. And that clearly is an issue. And this is especially in HIV infected people, that they have the highest HCV co-infection rates. And amongst those, it is MSM that contribute to this high reinfection rates. Again, highlighting the issues with finding these patients and linking them to care, and then actually treating them and treating them successfully. So it just shows you the number of cases in the US with chronic Hep C infections, about 3.5 million. And as you how many do actually know that they have Hep C, and how many have access to care, how many have confirmed a Hep C infection and have undergone further testing earlier with liver biopsy or genotyping, and have received treatment, and finally have achieved SVR. So you can see this is a major problem, finding out patients and linking them to care. And Dr. Solomon can attest to that and his efforts at finding these people and exactly taking care of this issue. So another thing that I wanted to give you an update on was what was presented at CROI just recently that brings the issues with Hep C treatment. So I've tried to group them into separate areas of interest, and one is improving access to care. And so this study is statewide, done in the United States, just testing people and linking them to care. Another thing that they are trying is trying to treat patients within the primary care setting and not having to send them to specialists. And treatment as prevention was presented in this abstract, where HIV positive MSM in the Swiss HIV cohort study, there was a 50% reduction in new infections if you find these patients and treat them. So treatment can be used as a way to prevent new cases. What about HCV treatment outcomes? During the interferon era, we were very selective in who we would consider to treat, and definitely people who injected drugs would not be considered eligible for treatment because we wanted a patient who was compliant. In the current setting, it's people who inject drugs who continue this epidemic. It's not somebody who acquired the infection 20 or 30 years ago and is no longer using IV drugs. So this study specifically looked at people who inject drugs, and there was a 91% cure rate. One interesting thing they noted was there was heavy alcohol use in this group. So active injection drug use should not be used as an exclusion criteria for treating these patients. What are the predictors or the predictors of lack of hepatitis C clearance among people who live with HIV? And this was a study from San Diego. One of my colleagues, or several of my colleagues, have done this, and led by Chris Matthews. And so the thing that stood out was psychiatric illness and illicit drug use in bivariate analysis. And in a logistic regression analysis, only psychiatric illness stood out. Psychiatric illness is not an exclusion criteria for using DAAs, but what the authors suggested was that it may have something to do with compliance, but they did not look at compliance. So psychiatric illness may be connected to compliance. Treating acute HCV infection. So if you recall, who should we treat? And it listed people with chronic HCV infection. And by that definition, patients with acute HCV infection would be excluded. But this abstract, again from CROI, looked at treating patients with acute HCV infection. And acute infection was defined as an estimated date of infection, which was 26 weeks prior. And so again, they just showed the same findings or the same success with treatment or with SVR12. And in addition, they also used a shorter course of 8 weeks and achieved SVR12 in 52 out of 53 HIV positive MSM. What about resource limited settings? So these treatments are fine for using in settings where we have the resources to find these patients and link them to care. But what about in resource-limited settings? And again, this is Dr. Solomon and colleagues have looked at the first step they're approaching is how do we find these patients who are co-infected, and so using a cumulative incidence-based approach. And again, you see this is another YRG investigator, Dr. Sarvanan, evaluation of dried blood spot HCV RNA quantification and genotyping. So again, looking at another way of collecting and transporting these specimens so that we can quantify HCV RNA and genotype them. And they showed that there was a good correlation between plasma and dried blood spot assays. Feasibility, efficacy, and safety of these DAAs in resource-limited settings. The study was done in 3 countries in Africa, in Senegal, Ivory Coast, and Cameroon. And they were able to have a 90% SVR12. So it can be used successfully with good results. So the DAAs have made eliminating hepatitis C a real possibility. Remarkable advances in HCV cure with short course and well-tolerated therapy have raised this possibility of eliminating the disease worldwide. And so this led the WHO to release their HCV targets for 2030 of 90% reduction in new infections, 65% reduction in hepatitis C mortality, and 80% who receive treatment. And so the strategies include prevent, test, and treat. So to summarize, DAAs have simplified treatment with a briefer regimen, minimal monitoring. New drug availability and guidelines are constantly changing, so any update this year is already out of date next year. Present and future challenges include identifying cases, preventing or treating reinfections. Resistance-associated substitutions are also going to emerge as a problem, and they are already a problem. And drug-drug interaction is definitely an important issue. It is possible that we may be able to eradicate hepatitis C, but I say that with a grain of salt because to date we have not eradicated any infectious disease by treatment alone. The success we've had with smallpox is vaccine, so really what we need is a vaccine, but definitely the DAAs can significantly bring the number of hep C infections down. I'd like to thank the YRG team for inviting me again, and for the projects have successfully completed and the future projects to come. And I would also like to thank my colleagues and my mentors, Scott and Davey, and Chip Schooley, who usually gives this talk, and he's not here. David Wiles, who's a collaborator on one of my hep C treatment clinical trial, and Dr. Benson. Thank you.